So, today we're going to focus on one of the most essential foundations of successful endodontic care, and that's accurate diagnosis. And I really want to emphasize how important this is because many complications we see in endodontics don't come from over instrumentation or ledging or obturation issues. They come from the very beginning when the clinician identifies the wrong source of pain. Once you start with an incorrect diagnosis, every step after that becomes essentially the wrong treatment for the wrong problem. So, in endodontics, we're constantly balancing biology with clinical decision making. We deal with the dental pulp, the periapical tissues, and the entire range of diseases that affect them. But the treatment only works when it's truly indicated. That means we need a structured approach, gathering a detailed history, evaluating symptoms carefully, performing appropriate tests, and interpreting all of that information with a clear understanding of how pulpal and periapical tissues behave in health and disease. When any part of that process is rushed, skipped, or misinterpreted, we open the door to unnecessary root canals, persistent pain, or missed systemic conditions. And one of the biggest challenges, probably the area where younger clinicians get tripped up the most, is distinguishing odontogenic pain from non-odontogenic pain. And that's because so many non-dental conditions can imitate toothache almost perfectly. If we don't recognize those patterns, we may treat a tooth that's completely normal while the real problem continues. Odontogenic pain. So let's start with odontogenic pain. When the pulp or periapical tissues are the source, the pain usually presents with some consistent characteristics. It's often acute and it can wake a patient from sleep. That's a very important detail to ask about. In the early stages, patients can usually point to the tooth or the region fairly accurately. And clinically, tests like percussion, palpation, and thermal stimulation tend to reproduce or clarify the symptoms. We almost always find an etiologic factor, deep caries, a leaky restoration, a crack line, or trauma. These are classic contributors to pulpal inflammation. And thermal testing is extremely useful. Inflamed pulps tend to react with intense, lingering pain, whereas necrotic pulps don't respond at all. Another key feature is that odontogenic pain usually decreases when we administer local anesthesia. If the anesthetic effectively eliminates or significantly reduces the discomfort, that's a strong sign the pain is indeed coming from that tooth. Now, as the disease progresses, odontogenic pain may become more diffuse, and the patient might feel like multiple teeth are involved. But with methodical testing and correlation of findings, we can still usually identify the primary source. Non-odontogenic pain. Now let's talk about non-odontogenic pain, because this is where misdiagnosis becomes incredibly common. These patients often arrive with a long, frustrating history, multiple failed dental treatments, several root canals, maybe even extractions, and yet the pain persists. And that alone should make us pause and reconsider the diagnosis. Non-odontogenic pain often cannot be localized clearly. Patients may point to a general area rather than a specific tooth. Clinically, the teeth look normal, no decay, no defective restorations, no radiographic signs of pulpal or periapical disease. And one of the most important clues is that the pain does not predictably improve with local anesthesia. If anesthetizing the region doesn't change the patient's symptoms, we have to start thinking beyond the tooth. Some of the most clinically relevant non-odontogenic conditions that can imitate dental pain include maxillary sinus disease. This often presents as a dull pressure or fullness. The discomfort can be referred to the premolars and molars, and changes in head position, like bending forward, can make it worse. The teeth usually look completely healthy, and pulp tests are often normal. Myofascial pain. This is extremely common in the orofacial region. Patients show tenderness in the muscles of mastication, and they may describe diffuse or shifting pain. Dental findings, again, are normal, but the pain patterns often lead to unnecessary endodontic treatment if the clinician doesn't palpate the muscles carefully. Temporomandibular disorders. These cause pain on palpation of the TMJ or surrounding muscles, sometimes accompanied by clicking or popping. Parafunction, trauma, prolonged opening, these are common triggers. The teeth look healthy, yet the symptoms can easily be mistaken for pulpal pain if we don't evaluate the joint. Trigeminal neuralgia. This is one of the conditions most frequently misdiagnosed as tooth pain. Patients describe sudden, intense electric shock like episodes, typically unilateral. Light triggers like chewing, speaking, or even a gentle breeze can provoke the pain. And a very important point, this condition usually does not wake the patient from sleep. Despite the extreme severity, that detail differentiates it from classic pulpal pain. Referred pain. This is where things can become especially confusing. Because of the convergence of nerve fibers, pain from one tooth can be felt in another, or pain from non-dental structures like the sinus, cervical spine, vascular structures, or even the heart can present as toothache. This is one of the main reasons normal teeth get treated by mistake. Among all referred pain sources, cardiac-related pain is one of the most critical to identify. Conditions like angina or myocardial infarction can refer pain to the mandible or the teeth. The discomfort may increase with exertion and improve with rest or nitroglycerin. And once dental pathology is ruled out, urgent medical evaluation becomes essential. So let's keep moving, but let's tighten this up and focus only on the most clinically important points, the things that genuinely matter for avoiding diagnostic mistakes during the patient interview. All right, so the first place mishaps happen is with the chief complaint. And honestly, this is one of the easiest areas to mess up. You have to let the patient speak in their own words. Their description, the exact phrasing, gives you critical information about the nature of the problem. And when we interrupt them or rephrase things too quickly, we lose details and we break trust. Remember, patients measure how much you care by how well you address the reason they came in. Ignoring or glossing over the chief complaint doesn't just harm diagnosis, it damages the clinician patient relationship. The next major area for errors is the medical history. This is where a lot of clinicians get too comfortable. But systemic disease plays a huge role in endodontic diagnosis and treatment outcomes, and missing something here can put the patient at risk. Let's walk through the big categories, the ones that truly influence endodontic decision making. First, cardiovascular disease. Conditions like hypertension, arrhythmias, ischemic heart disease, or a recent myocardial infarction can dramatically change how we manage the appointment. Epinephrine has to be limited, usually to 0.04 milligrams, and in certain cases, like a recent MI, unstable angina, or uncontrolled hypertension, it's contraindicated altogether. And elective dental treatment after an MI should be postponed for about 6 months. Even when urgent care is needed, you coordinate with the patient's physician. Antibiotic prophylaxis for endocarditis is only used for the highest risk patients, but when it's indicated, it's absolutely essential. Now, for for patients on anticoagulants or antiplatelet therapy, the key point is this: you do not discontinue these medications for endodontic treatment. Whether they're on Coumadin or a DOAC like apixaban or rivaroxaban, the focus is on local hemostatic measures, not stopping the medication. And remember, Coumadin interacts with drugs like metronidazole or fluconazole, so those need to be avoided. All right, moving into diabetes, because this one significantly impacts pulpal and periapical health. Poorly controlled diabetes reduces healing potential and increases the prevalence of apical periodontitis. Knowing the patient's HbA1c gives you a good sense of their risk profile. Controlled diabetes behaves differently from uncontrolled diabetes, and treatment outcomes reflect that. Now let's touch on hematologic conditions because these directly affect how safe your treatment is. Patients with sickle cell disease often present with spontaneous pulpal necrosis or facial pain without obvious dental causes. Patients with hemophilia or von Willebrand disease have serious bleeding risks, so NSAIDs should be avoided, and factor replacement or desmopressin may be needed for invasive procedures. This is where proper coordination with the patient's physician is critical. And then we have medications like bisphosphonates and denosumab. These are huge in endodontic decision making because they're associated with medication related osteonecrosis of the jaw. That means any surgical manipulation of bone, including apical surgery, has to be approached very cautiously. Denosumab is also linked to external cervical resorption. So, yeah, these meds absolutely matter. Finally, chronic kidney disease. CKD and end-stage renal disease can produce radiographic changes that look like periapical lesions, so misdiagnosis is common. These patients often cannot take NSAIDs or certain antibiotics, and many are on immunosuppressants or anticoagulants, which complicates treatment. All right, so now that we've covered the medical history issues that can lead to diagnostic mistakes, let's shift into another group of conditions that can complicate endodontic diagnosis: neurologic disease, cancer therapy, pregnancy considerations, lifestyle factors, and then the dental history and the clinical exam itself. These areas are really easy to overlook if you're not intentional, and they're a major source of misdiagnosis. All right, so let's start with neurologic conditions because these can mimic orofacial pain very convincingly. Lyme disease, for example, can produce facial pain patterns that look odontogenic. And the key is that these cases often don't line up perfectly with dental findings. So when symptoms seem inconsistent or widespread, you have to step back and make sure everything fits logically before diagnosing pulpal disease. Multiple sclerosis is another big one. MS involves demyelination in the central nervous system, and it can actually produce pain that resembles trigeminal neuralgia. In fact, trigeminal neuralgia can occur secondary to MS. So, when the pain presentation seems neural, episodic, or triggered in an unusual way, this should stay on your differential. Now, regarding cancer and cancer therapy, this is extremely important for endodontics. Chemotherapy suppresses the immune system, and that alone affects healing and infection risk. But many cancer patients also take bisphosphonates, denosumab, or angiogenesis inhibitors, and you already know these are associated with medication-related osteonecrosis of the jaw. So whenever you're planning anything surgical, even something like incision and drainage or apical surgery, you need to know exactly what medications the patient is on. Sometimes you'll need a CBC to evaluate white blood cell count if immunity is a concern. And if the patient has received high dose radiation, more than about 60 GY to the head or neck, their risk of osteoradionecrosis goes up dramatically. In those cases, you avoid surgery whenever possible and coordinate very closely with the physician. Now, let's talk briefly about pregnancy, because this actually comes up more often than you'd expect. According to ADA and obstetric guidelines, endodontic treatment can be performed safely at any stage of pregnancy when necessary. Local anesthetics like lidocaine or prilocaine are considered safe, as well as antibiotics like cephalosporins, clindamycin, or azithromycin. Acetaminophen is okay, but should be used sparingly. The main caution is with epinephrine because it can reduce uterine blood flow. So you use the minimal effective amount and avoid unnecessary vasoconstrictors. Now, very quickly, smoking. Smoking increases the prevalence of pulpal necrosis and apical periodontitis. We don't yet know if it worsens endodontic outcomes, but it absolutely affects disease presence and severity. So it should be part of your diagnostic picture. All right, now let's move into dental history, because this is where a lot of misdiagnosis happens simply because clinicians forget to ask the right questions. Recent treatment with another provider, trauma, new restorations, TMD management can explain symptoms instantly. And when the patient has multiple complaints, you absolutely must obtain the history for each one individually. Grouping them together is a classic mistake. When pain is the main complaint, the questions you ask are critical. Things like where exactly the pain is, how it started, what triggers it, how long it lasts, whether it's spontaneous, if it interferes with sleep, whether posture affects it, and what makes it better or worse. Cold, heat, biting. Quantifying pain on a scale helps with monitoring over time. Missing these questions leads to shallow diagnosis and unnecessary treatment. All right, now let's move into clinical examination because this is where diagnostic mistakes either get corrected or multiply. A proper exam has two main parts: extraoral and intraoral evaluation. During the extraoral exam, you're looking for swelling, asymmetry, skin changes, sinus tracts, lymphadenopathy, all of which can explain pain before you even look in the mouth. A very common mishap is when extraoral sinus tracts get mistaken for skin infections. Patients end up getting dermatology procedures, antibiotics, sometimes even surgeries, when the real cause was a necrotic tooth the whole time. Then the intraoral exam. This isn't just a quick look. You're evaluating the mucosa, gingiva, palate, tongue, muscles checking for inflammation, ulceration, sinus tracts. And remember, sinus tracts do not always exit adjacent to the offending tooth. They can drain far away, so tracing with gutta percha is essential. Swelling assessment also matters. When it started, how fast it grew, whether it's fluctuant or firm, whether it drains. These details help you distinguish a periodontal abscess from a periapical one. Before testing, you examine the teeth themselves. Fractures, discoloration, caries, failing restorations. A discolored crown, for example, often indicates prior trauma or pulpal necrosis. Now let's go over clinical tests, because this is another area where mishaps are incredibly common. Percussion tells you whether the periodontal ligament is inflamed, but remember that inflammation doesn't always mean pulpal disease. Bruxism, occlusal trauma, or malocclusion can create percussion sensitivity without any pulpal pathology. Palpation is more specific. Tenderness usually implies periapical inflammation. Pulp sensitivity tests. Cold, heat, and electric don't measure vitality. They measure sensory response. Cold is the most reliable test, but it still produces false positives and false negatives if done incorrectly. Lack of isolation, poor technique, or failing to use a control tooth are some of the most common mistakes. Electric pulp testing has similar limitations. Small or calcified canals can give false negatives, and readings are not diagnostic of the degree of vitality. They only tell you whether the nerve fibers responded. Heat testing is the least reliable and should only be used when the patient specifically reports heat sensitivity. And again, isolation and comparison teeth are essential to avoid misleading results. Finally, probing. And this is probably the most underused diagnostic tool we have. Probing helps differentiate periodontal lesions, endodontic lesions, and true combined lesions. Without probing, you can very easily mistake a periodontal defect for a periapical lesion, or the other way around. All right, so let's keep moving. And now talk about one of the areas where misdiagnosis happens all the time, periodontal defects and how they relate to endodontic disease. And this is a place where a quick or incomplete exam can mislead you into performing the wrong treatment entirely. So when you're probing around a tooth, you really have to distinguish whether that defect is endodontic, periodontal, or a true combined lesion, because each of these behaves very differently and the treatment is completely different. All right, so when we have a periodontal defect of endodontic origin, it almost always comes from a tooth with pulpal necrosis. The probing is usually normal except for one narrow, isolated, deep point. And the important thing here is that this defect is not a true periodontal pocket. Once you clean, shape, and obturate the canal system properly, uh, these defects tend to resolve completely. A common mistake is not probing thoroughly enough and assuming the defect is periodontal when, in reality, it's being driven by a necrotic pulp. Now, periodontal defects of true periodontal origin behave differently. These are associated with generalized gingivitis or periodontitis, and the tooth responds normally to pulp sensitivity tests. When you probe, you'll often feel that step-down pattern. The defect deepens gradually, then comes back up on the other side. And the big mishap here is when the clinician assumes these pockets are caused by pulpal issues and performs a root canal, which does nothing for a purely periodontal lesion. And then we have true combined lesions, which honestly are the ones that confuse people the most. These have both periodontal and periapical components. The tooth is typically non-responsive to pulp tests, and the probing pattern is wide, V-shaped, extending apically. These lesions require both endodontic and periodontal therapy. A common error is assuming that one treatment alone will resolve it. It won't. Now, let's talk about mobility, because this is one of the most underused diagnostic tools we have. Mobility tells you about bone support and inflammation, and it gives you important clues about prognosis. Teeth with periodontal disease may be extremely mobile because they've lost support, and that mobility doesn't resolve. But if a periapical abscess causes sudden mobility, that mobility usually decreases dramatically after root canal treatment. So the mishap here is assuming all mobile teeth have hopeless prognosis, when really the cause determines the outcome. Okay, now let's shift into radiographic examination, because this is a major area of misdiagnosis. Radiographs are essential, but relying on them too much is a huge mistake. They're two-dimensional, meaning they can hide anatomical structures, make lesions appear larger or smaller, and even completely conceal periapical disease depending on the angle. You always need multiple images from different angulations, especially in the posterior maxilla, where sinus overlap can mask pathology. CBCT overcomes many of these limitations by giving us a 3D view. It's particularly useful in complex cases, unusual anatomy, traumatic injuries, or when previous treatment has failed. But it does come with higher radiation exposure and cost, so it's used selectively. One of the biggest errors is assuming every radiolucency at the apex represents endodontic disease. Many radiolucencies are actually nonodontogenic, anatomical structures like the mental foramen, the incisive canal, the maxillary sinus, marrow spaces. These teeth respond normally to pulp vitality tests, and changing your radiographic angle usually shows the lesion shifting relative to the root, which tells you it's not dental in origin. Beyond anatomy, there are benign lesions that mimic endodontic pathology: early cemental dysplasia, ossifying fibroma, cysts, central giant cell granuloma, and others. The lamina dura may still be intact and pulp tests are normal. These require biopsy, not endodontic treatment. Malignant lesions, on the other hand, tend to cause rapid destructive bone loss: lymphoma, carcinoma, osteosarcoma, myeloma. And here's the key: the affected teeth often remain vital. That's why vitality testing is so critical. It's often the only way to avoid mistaking a malignancy for an endodontic lesion. So the real takeaway is that radiographs alone cannot diagnose pulpal or periapical disease. You need the clinical findings, the pulp tests, the probing, the history, everything together. All right, so before we wrap up, I want to leave you with the most important idea from this entire topic. Endodontic diagnosis isn't about being fast. It's about being thorough, being systematic, and honestly being humble enough to question your first impressions. Most endodontic complications don't come from the obturator or the file. They come from mistakes made long before treatment begins. When we take the time to listen to the patient, evaluate their history, examine carefully, interpret tests properly, and use radiographs appropriately, we dramatically reduce misdiagnosis. And that means fewer unnecessary treatments, fewer complications, and much better outcomes for our patients. All right, that's going to conclude this session. Make sure you practice these diagnostic steps in a structured way every single time, because they truly are the foundation of safe and successful endodontic care. Thanks for being here, and I'll see you in the next lecture.